Now we will move on to the next session. This is the most important session, very important session, which is very often forgotten almost all the clinics and almost in all the hospitals. I have never seen a clinic or a hospital in my 37 years of life career, professional career, where they are recording the blood pressure correctly. Just they will take some blood pressure and put it to the physician and they will put them on tablets. So this is a very important topic. I am welcoming Dr. Nikita Mironov, PhD. He is a 3-in-1 person. See, 3-in-1 means he is a cardiologist, he is an internal medicine physician and a clinical pharmacologist. And he is affiliated with the Moscow State University, Lomonosov. And already the time is running out. Just I will tell only a few things about him. He has authored 16 scientific publications, including papers in high-impact cardiovascular journals, such as the European Journal of Heart Failure, and also his clinical research experience includes coordination of phase 1 to 3 clinical trials in hypertension, cell therapy and refractory angina, as well as serving as site principal investigator for the multi-center Carmen CHF registry. Now the stage is for Dr. Nikita Mironov to start the very important session, which I like it very much because I hope that you all will agree, in no clinic and in no hospital, nobody follows the rules of measuring a correct blood pressure level. And everybody talks, this conference itself is about hypertension, but with your conscience, please tell, in any clinic or any tertiary care hospital, including Apollo where I worked, I have never seen blood pressure is recorded as mentioned in the textbook of medicine. So, even if you have not listened so far, my dear colleagues and my dear PGs, please listen to him. There are some 15-20 things which you have to see. And our doctor, who is an expert, he will be explaining to you. Over to you, sir.
Good morning, dear colleagues, dear chairpersons. Today I want to talk about how we measure blood pressure, and the main idea is simple. Even small, regular mistakes in measurement have a big cost. They hurt the patient and they hurt the whole healthcare system. And we also show a way how to fix it without making the visit longer. Okay, let's start from the size of problem. Heart and blood vessel diseases are the number of cause of death in the world. It's the top 10 cause and it's on the top. In Russia, about 38% of all deaths come from these diseases. So this is not a small problem, it's the biggest cause of death, and blood pressure is in the center of it. What causes of these deaths? The answer that we have was published on Lancet 2020. So there are the same risk factors for men, women, and for all ages. The number one cause is high blood pressure. And it's higher than cholesterol, smoking, bad diet, and air pollution. Let's think about it. And the biggest risk factor we treat is the number that we write down ourselves with a cough in a few minutes every single day. And it connects with every person that listens to this lecture. So the quality of that number is very important. And we see the same thing when we look on cardiac death. High blood pressure is again the top risk factor. So if we want to save lives from heart disease, blood pressure gives us the most power. Every small gain in accuracy helps our patients. this is why I'm talking today about something simple, how we measure. And this problem is growing. Look, experts say that by 2050s, high blood pressure will rise about from 51% to 61%. And another factors such as obesity and diabetes mellitus will rise also. So in future we will have more patients and we will do more measurements. And any hidden regular mistakes in those measurements will cost more and more. Now it's hard truth. So WHO from 2025 says that only 1 patient in 5 with high blood pressure in Russia is controlled. Look at the steps: diagnosed, treated, controlled. And we lose patients and we lose diagnosis in every step. So we lose quality of life and prognosis. So what's the real problem? We can treat almost patients with high blood pressure. So on the first step, when we use combined therapy, we can help almost 60% of patients, and all methods that we routinely used during our clinical practice can help up to 95% of patients. So we can cure and we could cure arterial hypertension, but our problem is finding it correctly, and finding it depends fully on measurement. Okay, why is pressure measurement is so weak? It has 3 problems that connected with 3 persons. It's a patient that don't know the rules, it's the nurses that know the rules but do it incorrectly, and doctors who know the rules but haven't enough time. So this is the problem number 1, the office classification that has several grades for patients who are not on drugs. But every day we use the same levels for patients who are already taking drugs, and it is a big mistake. So patients controlled by drugs is not the same as untreated patient with the same number, and this changes how we describe access risk factors in disease and how we change the treatment. So easy solution for this problem is investigation before treatment. Firstly, we need to diagnose. Secondly, we need to treat. Now the deeper issue, problem number 2, mistakes in the measurement of itself. Look at these 2 chairs from a study from China. Left is estimated prevalence of people with high blood pressure, and on the right is estimated control rate. Now watch the bars. A shift of only 5 moves the prevalence from 33% to 53%. And it also doubles or halves the control rate. So the patient didn't change, only the measurement can change. And the same thing happens in US, UK, and any other countries. Let me give real examples by country. So in the US, 2 millimeter underestimation of diastolic pressure cut prevalence by 17%. In Canada, a shift of 5/3 lowered prevalence by 30% and almost doubled of control rate. If you add 5 to systolic, prevalence more than doubled. In the UK, a 5 millimeter error in diastolic change prevalence by plus 73% or minus 47%. These are not small errors. On paper, 5 millimeters is the difference between country that healthy and an epidemic. How to solve problem number 2? Use an accurate BP device and follow the standard BP measurement procedure. It starts with device. A validated automatic monitor is important because accuracy must be checked not only on the bench but also in real patients. And now the standards help us to validate special monitors, and we have several good monitors to use in clinical practice. Device is called accurate when most reading are within 5 millimeters on reference. And that is exactly the size of error that can change whole country numbers. But the device is not only half of the story. Doctors need to do according to clinical guidelines. They need to measure BP after 5 minutes seated comfortably. BP cuff needs to be on the heart level. You need to be able to measure orthostatic and femoral blood pressure. 3 times management is a gold standard. Measure BP on both hands during the first visit is obligate. So it takes a long time to do every step from this algorithm. So small mistakes in technique almost always push the reading up. A lying patient reads higher than sitting one. No back support raises the reading. The arm with the cuff must be supported at heart level. If hands low, the number is too high. And crossed legs also make systolic and diastolic higher, and this adds a few millimeters and they add up together. So next, never trust single reading. It's the most popular problem because we haven't enough time to do a series of investigation. So a study in 2023 with almost 18,000 patients shows that several standards reading predict heart risk much better than one reading. On average, the first reading is about 8/3 higher than next ones. So this is well-known first reading effect, and we all know that is. If we repeat and take average and later readings, the classification becomes much better. One number is simply not enough to label patients for life. Also, we need to measure both arms at the first visit, and we need to do several steps. Step 1, check both arms at least once, and we need to use arm with higher pressure. Step 2, stable difference of more than 15 millimeters may show arterial disease, and it also can be useful in another factor of risk that connected with the lipidemias. And step 3, use arm with higher pressure. You also need additional checks: lower extremity BP, standing BP, and appropriate cuff sizing. So this is well known. Why do we don't do it? We come back to the third reason from before. The main barrier is the time and staff workload. So for the doctors, they know rules but haven't enough time to do it. And what's the solution? My colleagues from Peter Telegin company presents BP Lab, and it also was presented on yesterday lectures. This monitor can help to solve problems with less time. And here's the key point. With automation, we need only about 7 minutes, several readings, current cuffs in both arms at the same time are done, and the accuracy steps do not add the real work and make visit longer. So we need only 7 minutes to do all the guidelines. Now our final results. We did angio project when we tested 289 patients. Was divided 47 per 53% male and female, and median age was 50 years old. So 100% patient get validated management, not most of all of them, which the standard automatic measurement high blood pressure was found in 24% of men, in 37% of women. That also represent the general population data. So these numbers match the expected population, not raw numbers from the quick reading. And the most important result, the automatic reading was average 4.5 millimeter different from the routine reading. So we can diagnose more hypertonics using simple rules. This is not a small error we can ignore, because we know that 5 millimeters distinguish healthy country from pandemic. So in our university, we always finish with quotes from great people. Today I want to finish with Socrates, who said, "Knowledge is only good, ignorance is only evil. In our field, the knowledge that matters starts with accurate number, and the measurement is wrong, everything is after wrong too. The diagnosis, the treatment, and the statistics. That's why precision is not a technical detail, but clinical responsibility. Every value we record represents a real patient, real decision, and real outcome. We protect safety and trust of those who we treat. So, good medicine begins with good management. In conclusion, accurate management is the cheapest and strongest step that we can take to improve care for high blood pressure, and now automation let us to do it normal within 7 minutes visit. Fix the management and we'll fix the base of everything else. Thank you very much for your attention. I will be happy to answer questions.
Well done, Dr. Nikita. Before opening the session for questions, I would like to add a few more points for the benefit of our postgraduate students. See, while recording the blood pressure, actually it will take minimum 10 minutes for the nursing officer to send the patient if they follow the correct way of measuring blood pressure. But it is not being done anywhere. So, at least you know how to do it correctly, as our Dr. Nikita has told. And one or two more points which I would like to add is, you make the patient sit in a chair and don't measure the blood pressure for 5 minutes after he arrives. And half an hour after eating, and immediately half an hour you give rest after smoking, and 24 hours no alcohol. And he should sit in the chair with the back supported and the feet rest on the floor, and both arms to be measured and correct cuff, wide or narrow cuff to be used. And apart from that, you have to see to it that the cuff snugly fits the arm. But we have seen nursing officers taking BP with the cuff, and the cuff will be very loosely fitting the arm and falling down. So many things are there which you have to take care, and I am leaving it to the audience to ask, to limit their questions to one or two, as already time is running out. Thank you.
Dear colleagues, thank you for your attention.
I would like to thank our speakers for sharing their invaluable knowledge and our chairpersons for delegating this session. May I now request our chairpersons, Dr. Vinata ma'am and Dr. M. Subramaniam sir, to kindly felicitate our speakers, Dr. Lakshmanan and Dr. Nikita Mironov. May I request Dr. Mohan Rao sir to kindly please felicitate our chairpersons for today. May I request Dr. Mohan Rao sir to please felicitate our chairpersons as well. Thank you, everyone. I now request all dignitaries to please move to Hall A for the oration and keynote address. Thank you.